we'll come to the last item on the agenda of the day. We have titled it as Broken Heart Syndrome. I always have been very inspired by listening to Dr. Kini, who works at Satyasai Whitefield as a lead consultant and teaches dozens of people and hundreds of people every year. Very good communicator. It will be lovely to hear him what his concept of broken heart syndrome. Old wine in the new bottle.
Yes, sir. Thank you so much for that. In a hall full of cardiologists, we are discussing broken heart. It's nice. I just titled it as "Don't Leave the Hall and Break My Heart," essentially. So this is a mystery. Deepak speaks of something which is very concrete. I love the way I always listen to him when I learn something and go. But this has always been a mystery. A lot of people call it Takotsubo. It's Takotsubo. I knew it a few days back. So in any case, this has also been called as an apical ballooning syndrome, and it's more appropriately termed as stress-induced cardiomyopathy, also called as a broken heart syndrome, as sir was saying. So, it's a reversible syndrome. It's important to understand that it's reversible, but it's not innocuous. There are two different words. It's not innocuous. It can be reversed in up to about 85 to 90% of cases. And as we have generally known, it's more common in postmenopausal women. I'll actually go through a series of hypotheses which started in 1950s, 60s. Actually, though I have put it that Sato et al. Have described it in 1990, there was a case described by Dr. Braunwald much earlier in 1982 as well. But after all this time, still it was actually considered idiopathic for a long time. Idiotic doctor, pathetic patient. But then it's always important to understand the etiology of it. The name actually comes from this trap. It's an octopus trap which is used as an earthen pot. It's not used anymore. They're using much better tools, but it's a Japanese term. Why do we need to know about it? In this Congress, why do we need to know about it? Because it was generally considered that Takotsubo cardiomyopathy was a self-limiting condition, but it's not, because if it's left untreated in about 10 to 15% of people, there's even mortality. It's considered as, in that subset, it can have a very high morbidity because AF develops, heart failure develops, people die. CVA can develop, and it's very morbid. Even then, we still do not have an international guideline for it to standardize the approach and treatment. As I told you, this is actually a comparison of two graphs between the acute Takotsubo and acute coronary syndrome. There's hardly any difference in the mortality and even in the heart failure. So it's mortal in about 10 to 15% of patients, but if you see the mortality percentage, it's about 4 to 6% in the first month or two, and then it is 5% at 5 years. That means you need to target then in the first 1 month or two that you need to save the patient. So what is the pathophysiology? Whenever we don't when we don't know one thing, then we invoke too many things. That's what happens in medicine. But it's generally considered as a conglomerate of these four things. That is, there is a sympathetic surge. You have a catecholaminic aggression, which leads to the others, typically a coronary vasospasm. There can be microcirculatory dysfunction on a background of sympathetic hyperactivity, essentially with normal coronary arteries. So this is, it's a very busy slide, but it went through its own evolution because people thought this was something else. It was an estrogen deficiency syndrome. There was an LVOTO theory. Some people said it's genetic. Then there was an inflammation hypothesis. It's gone through its evolution. But essentially now we understand it, that there is a central sympathetic surge, which sort of pushes the whole thing. As I said, you have a multivessel vasospasm. You have inflammation, there is a lot of nitrous active stress on the heart, along with an element of microvascular dysfunction, which in various kind of subsets might have a various amount of contribution. So this is typically how an LV angiogram of a Takotsubo is seen. This is actually from the internet, because you do not get such a classic image really, where you have significant amount of basal hypercontractility with the apex ballooning out. It's rare to see these kind of images these days, but then when they do, this is absolutely classical. And this is the apical ballooning syndrome for what it is called for. So exactly why does this happen that a certain part of the heart misbehaves and a certain part is fine? So actually what they have found out in biopsy studies is that the proximal part of the heart, which is actually normal in Takotsubo, that has got more of a cholinergic predominance, while it's the apical part which has more of an adrenergic predominance. And there is an actual hinge point which they have found out where that transition happens, where you have the Atlantic and the Pacific which never mix. But then it's not really as crystal clear as that. But then you do have a kind of a differential kind of receptor predominance in the heart, because of which this has been, sort of enunciated as an apical ballooning, because it's more of adrenergic predominance in the apex. A lot of stressors have been told. This is something that we've all heard about. One can become happy and even develop it. The one on the right says that prize-winning, marriage, very, very touchy subjects, of course, reunion with a loved one, all of these. That means it's basically a surge of sympathetic overactivity which causes it, along with, of course, the known factors, which is that if there is a bereavement in the family, hypothyroidism can cause it. Stroke has been seen to be associated because there is a neurocardiogenic interplay. So all of these have been associated. There's even a post-operative Takotsubo, I'll speak about that, which is because of infusion of catecholamines. So this is the typical octopus spot appearance, but then, this is how the MRI looks with a normal or a near normal coronary. It has to be a sine qua non that the coronaries have to be normal. So this is, if you see this is the part of the heart that's not contracting on MRI, very clear. And if it does develop stasis, this is where the problem comes, because these are real life pictures from our hospital where we've seen that there is a clot there now actually developing. And that's what sort of embolizes and increases the risk of stroke. So the variance which I've been told is the classical one. If you see in terms of numbers, 70 to 80% is the apical phenotype. This is the classical Takotsubo. The third one actually is a reverse Takotsubo, where there is a basal, you have a hypokinesis and an apex may be contracting well, and a mid-ventricular LVOTO type has been described, also as a focal pattern has been described. This is a very new pattern, a focal pattern which is very, very similar to an acute coronary syndrome. That's the issue. I mean, as physicians, as cardiologists, we should know where it transitions, where do we make a diagnosis of an ACS versus TTMI, because the treatment is completely different. So a classical ECG is this, which at admission you would think, these are all those Wellens patterns and those LAD patterns, but then if you see the same thing at third or fourth or the 6th month follow-up, it tends to revert almost completely. So since there are dynamic and varied morphologies of what is the ECG that can present, one thing that has been told, this is pretty new, and I want all of you to understand this, that this is called as the INTERTAC score. It's an international Takotsubo diagnostic score, which has pretty high specificity for MI versus ACS versus a TTC, where you have each of these criteria, typically a female, either an emotional trigger or a physical trigger. It almost comes down by 10 points. So if there's an emotional trigger, it's given a lot of more importance. Absence of ST depressions, particularly other than, it's not like a myocarditis basically, psychiatric or neurological disorders in the patient, and acute prolongation. So if we add up those, if the score is more than 50, it's easy to use really. If it's more than 50, there is a 95% specificity for a patient to have Takotsubo. That means if it is not there, then you're not probably having a patient with Takotsubo. And the same thing is if it is less than 31, right? If this score is less than 31, it's more likely to be an acute coronary syndrome with, again, a specificity of 95%, a sensitivity of 90 actually. So this is the typical criteria on which the TTC is diagnosed. Again, it's important to realize that this does not require you to have an angiogram, prima facie. It might be done later. But then if you see this typical criteria, which is the classical criteria that we all read in our cardiology, in our physical, in physician times, is that there is a left ventricular, you have a wall abnormality, which is not regional. It tends to cross a single coronary segment. An angiogram should show that the coronary stenosis is less than 50 with no evidence of acute plaque rupture. The patient should have new ECG abnormalities or a remarkable increase in cardiac troponin. This has been challenged because it's not usually, the HS drop it will not cross 6 to 10. and a trop will not cost 25. So that's why at that point in time, that is what the diagnosis was, because we couldn't use this anymore for the, if you had like a moderate to high increase, because that tends to go towards ACS. And an absence of myocarditis of Youkrow-cytoma. So, prima facie sitting in your OPD, if you have something like this, or if you have in the ER, it's difficult to diagnose with this, though it gave us a rule of thumb as to what TTC could be imagined as. So, if you compare this is again a little busy slide, but I tend to actually go to the arrows which are important. If you have a systolic murmur in that patient, if you are seeing him in the ER, it's a lot more likely to be, say, a free wall rupture in an MI if he's still alive. But then it's more of a dynamic LVOT if it's TTC. You do not have classical risk factors. Even if it's a postmenopausal lady, she may not have the classical risk factors for it, but generally we understand that AMI, you will have a patient with a certain amount of risk factors. The BNP, now the troponin is moderately increased, and the BNP is markedly increased. So it's actually a ratio which has been enunciated from a study in Turkey, where they have seen that the HS trop does not usually cross 6 to 10 when it is markedly increased. We know that it's in 3 figures, sometimes in 4 figure in MI. BNP is markedly increased. So it's a cardiomyopathy with heart failure. It's not so high in AMI, but then there's no real cutoff there. If you see at the ECG, there are usually no Q waves, right? But generally in an evolved MI you would get it, and you don't really get a bundle branch block that commonly in a TTC. It's more of narrow QRS with an ST in the anterior leads, but in an advanced AMI it can cause, depending on the amount of territory involved. The important thing is that the regional wall motion is not limited to a single territory, which is a lot more likely in AMI, particularly if there's single vessel disease, but then it's not again if it is a, if you have a global hypokinesia, but still the regionality of it is not there in TTC. So all of these can be taken as a sort of a marker in the OPD, but the intertac, again I'll go back to that, requires nothing of an angiogram, nothing of this. So this gives you a starting point, a very good starting point to know in the ER what could be TTC versus ACS. The diagnostic criteria, as I said, have gone through a lot of modifications. Mayo Clinic, Japanese, I'm not going to bore you with this, Gothenburg criteria, Johns Hopkins criteria. Then, you have got the Italian network, it's more for, all our students who are here. But then this is if you see the intertac, if you see the class 1, the emotional is given 24 points, this is given 13, class 2. And class 2 divides it as secondary to physical activity, either a medical procedure or an acute sepsis or illness. While 2B is secondary to a neurological disorder. That's what is sort of echoed in that earlier slide. And Takotsubo with no identified trigger. Who are the ones whom you can really say are really going to be worsening in TTC? This is important. So what the ESC says is that in the heart failure sort of risk stratification model, if the patient is older with a BP of less than 110, with a clinical pulmonary edema, with EF of less than 35 or an LVOT of more than 40, this obviously requires an inpatient or at least an outpatient echo with moderate to severe MR. Apical thrombus is of course a late feature, or if the patient has got a contained LV rupture. All of these are actually high risk subset, but again they sort of cross over into an AMI kind of a etiology. But then if the patient is younger, if the QTC is like more than 500, and if the EF is 35 to 45, if there's a physical stressor, if the BNP I told you is high, so all of these can be a lower risk, but if you have a bystander obstructive CAD which is high, again it is a high risk, or if you have a biventricular involvement. The point is, how do you diagnose this? As I said, it's a ballooning of the dyskinesia of the apical segment of the LV with an increased dynamicity in the basal segments in the absence of obstructive coronary artery disease. The imaging methods have come a long way, because that is the first step that we get. We can go through the CMR, the angio CT, etc. But typically this is the appearance where you would have an apical dyskinesis, or you have an apical ballooning with the proximal segment contracting a little well. This is an echo image, usually upside down. In the same patient, you can see that you have, you have the basal which is contracting pretty well in an LV angio, but it's not seeing the same on an apex. MRI has been important because this sort of corroborates what I actually told you earlier in the pathology, that there is almost like a hinge point where the cholinergic and the adrenergic sort of separate out, which you can make out very clearly, because this is something which sees the heart in action outside of an invasive lab. The diagnostic workup typically, we have again tried to go towards the Intertac criteria, but then if you see in terms of an LV imaging, this is definitely the gold standard of diagnosis. End diastole, it's pretty good, and end systole, you can see that the apex balloons out. Focal Takotsubo came in a new entity where it is not very clear, it's only one segment of the entire myocardium involved, and actually this becomes important because again we are talking of a certain amount of regionality which AMI also can have an overlap with. That's where your troponins, your BNP and your risk factor like evaluation become actually very important. The management is dictated by the clinical picture. I come again to say that 85 to 90% will recover, but still 10-15% people can have morbidity and even mortality. So don't think it's innocuous, because the patients can go into pump failure typically, which might require a different line of treatment with mechanical circulatory devices. Patients can have acute mitral regurgitation, again that can be secondary to heart failure, coexist with heart failure and then worsen the situation. RV involvement is known. Now this is it's again not typically seen in the previous risk factors. RV involvement has been studied because now MRI has proven that it can cross just the LV, and even the RV can show RV strain comes down. That has also been studied. So again we might need MCS devices for that, and LVOTO can happen. So a therapeutic approach, if we see in terms of a general criterion, the frequent complications are if the patient can go about into heart failure, about 10-15% or even up to 40%. LVOTO is a little less common among the frequent ones. Cardiogenic shock happens in 1 in 5. So it's not innocuous. Again, I'll have to stress that. MR is not infrequent, 1 in 4. Occasionally patients do go into advanced heart failure, develop AF, develop thrombus, which can embolize into a stroke. Cardiac arrest can happen, and it is rare to get really bradycardias, or about 1 to 5% die. So this is a busy slide, but I try to cover everything, what all can be done. So if the patient comes with an obvious, PTS, it can go into a mild kind of failure, which is EF is actually good in the angios which I showed you. It's not really so bad. Patients can be needed to be treated with MCS support devices. LVOTO, we might need to give phenylephrine-based therapies or an RV pacing. If he's in frank cardiogenic shock, then of course ECMO, LVAD come in. If the patient rarely again gets into CHB or bradycardia, one might need to treat it symptomatically or with a PPM. That is if there is a CHB which actually prolongs, one might need a pacemaker. AF again, if there is a prevalence of that. So all these are less common, but then if you see in terms of a beta blocker, really, we tend to favor the short-acting ones, typically esmolol, and like in India we don't have landiolol, and we have to look for worsening. It's not that every patient worsens, but in those 10 to 15% of patients who do, it's more likely to develop into AF or even into heart failure, which can be refractory. For those interested, there is something called as a perioperative TTC. Now this is exactly not been very clear, but they say that patients who do undergo invasive surgeries can develop this, and we would get a call definitely from our anesthesia colleagues or the step down ICU intensivist, because they tend to develop all of these, and it's not very clear after that. But then there are clinical clear perioperative triggers. Like if there has been an inadequate depth of anesthesia, a lot of tracheal manipulation has been done, or if there is an exogenous infusion of epinephrine, I think that has been given. It's even been seen post stent implantation, what is called a Schoene's phenomenon. That's because of allergy. But then you need to take all this in the correct context, because not every perioperative patient would develop it, and a lot of times they are non-specific changes which tend to revert. But it's good to always do an echo in these patients, because you would never pick up TTC unless you think about it. It's like that. So the prognosis essentially will be worsening with say a refractory heart failure, or if the patient has stroke, etc. But then there is actually a full spectrum that they can go through a biventricular involvement, or there can be changes, or there is even free wall rupture that has been described. A couple of cases that actually happened during COVID. One was the patient who had developed severe irreversible myocardial damage. This is again in a COVID survivor who had a fatal TTC initially. He survived COVID but then developed TTC and died. And then that's the reason it's no more considered as innocuous or only a post-menopausal women syndrome that we were all taught about. In a nutshell, so if you want to tackle this, essentially, this is one slide which I actually made for the students to take home. So then we know that we are looking at a subset of STEMI whom we are trying to take a DD from. There is we have a catecholaminergic surge which leads to microvascular dysfunction. Typically, we know from the INTERTAC criteria, emotional and physical triggers, the patient can have a transient amount of LV dysfunction, but the important thing is non-regionality of it. It is only in the apex. It tends to cross more than one territory, not too high troponins, very high BNP, as compared to the reverse in MI. And in a nutshell, again, all of these can be the side effects, which are, if there is an apical, there can be a thrombus, there can be a CVA, and we might need to serially do the echoes. That's the most important thing. If you want to serially follow the patient whether he's improving or not. So this is the management, just for the sake of again reading, so we can have it as per how bad the patient is. If he's too sick, he might need an MCS support. If he's just above pulmonary edema, then you might be able to do it like on diuretic and anti-heart failure therapy. Thromboembolism will need its own therapy. And then you have to assess him pre-discharge. Is there a bystander coronary artery disease? Because it's possible that the patient has developed an apical ballooning and also has CAD. So then that needs to be treated again symptomatically or with the CAD drugs. And in the long term, one needs to assess for his thromboembolic risk and his heart failure risk. Thank you so much.
Thank you, Dr. Kini.
I'm sorry I overshot, sir.
It's fine, no problem at all. Because of this longer talk, we got clarified of so many important considerations and doubts and clarifications. I'm sure during the tea time, a couple of us would definitely interact with you.
Thank you, sir.
And also Dr. Deepak Padmanabhan, and both of you did a good job to hold back such a large audience into the auditorium post-lunch. Congratulations. And so also the first session by Dr. Sunil and Dr. Prabhakar. Indeed, since morning, friends, the hall has been full, and many of you have not left your seats simply because you wanted to understand what is new that is happening in cardiology and cardiac sciences. I'm sure the 3 T's of a translation, transmission and transformation has worked, and you would be transformed into a kind of well-aware physicians that you practice medicine as it should be, causing no pain to your patients, and make sure that you are adhering to the practices of good clinical practices. And we wish you on behalf of Academy all the best for having come in such large numbers. We hope to have a bigger numbers. In fact, if there are any feedbacks, please put it in the WhatsApp chat, and also you can give it to any of our colleagues and trustees. We'll be very happy to receive those remarks, and we apologize that we have taken 1 hour extra today simply because we have to kind of put in a lot of audiovisual people also have not got us. Okay, Dr. Prabhakar. Yeah. One second. Before that, let me present all the speakers, the momentous and the various. Thank you so much.